Greetings and welcome to this virtual town hall gathering focused on the theme COVID and the faith community. Where do we go from here? My name is Matthew Wesley Williams, and I serve as the president of the Interdenominational Theological Center, a historically Black graduate theological school located in the heart of the Atlanta University Center, right next door to our neighbors, Morehouse School of Medicine. At ITC, we say our mission is to cultivate prophetic problem solvers who commit to practicing justice and peace through a liberating and transforming spirituality. I have the privilege this evening of serving as the moderator of this important conversation. And first, I want to give a big word of gratitude to the Georgia Community Engagement Alliance Against COVID-19 Disparities, also known as Georgia CEAL, for calling this conversation and arranging this town hall. And so on that note, allow me to introduce Dr. Tabia Akintobi, Professor of Community Health and Preventative Medicine, and Associate Dean for Community Engagement at Morehouse School of Medicine. She is also the Principal Investigator for the Georgia CEAL Initiative. Dr. Akintobi?
Thank you so much, President and Reverend Williams. Thank you so much for moderating this important discussion. I appreciate all of my partners in good who represent leadership in rural, urban, and suburban Georgia, all of us united to ensure that we recover stronger than before from this pandemic. So Georgia CEAL, as our moderator shared, is the Community Engaged Alliance against COVID-19 disparities. And it came together urgently to address all the ways that Georgia was hot. And I mean hot for all of the wrong reasons, meaning having more Black, Latinx, and other populations who are disproportionately impacted by COVID-19. And we mean more hospitalization, more illness, and more death. What this pandemic has taught us is that it takes all of us to move extraordinarily quickly and urgently to issues like COVID-19. It also has reminded us of the important role of faith-based influencers, and those are folks who either are formally or informally stand in the gap to provide hope, to provide resources, and solace, both pre and post-pandemic. All of the issues that made faith influencers important still exist, whether it's diabetes, asthma, cardiovascular issues, or the issues of food insecurity, the importance of mental and behavioral health. And for all of these reasons, we know that faith influencers are critical messengers through which messages of hope towards mitigating the pandemic, getting vaccinated, and minding their mental and behavioral health are all important. So I hope that this demonstrates for those who chose to join us this evening the importance of this conversation and how we can all support and listen to the issues that are raised this evening to consider the path forward. Thank you, moderator, and thank you for all of my partners in good this evening. I look forward to not just a conversation, but collaboration and discussions towards the path forward.
Thank you, Dr. Akintobi. This is indeed an urgent conversation, maybe the most urgent conversation of our time. And so again, this evening, we want to gather under this theme. Where do we go from here? COVID and the faith community. And within this conversation, we want to discuss key issues related to the faith community's role in addressing the COVID-19 pandemic, specifically with regard to disparities that are disproportionately impacting communities of color. So tonight, we want to talk about the urgency of COVID in our communities and the impact, the disproportionate impact of COVID in our communities. We want to talk about the benefits of vaccination and other prevention efforts that are underway, and then to begin to explore together and really unveil how faith leaders and influencers have worked and can work towards stopping the spread in light of the unique role that faith communities play. And that unique role presents opportunities for understanding and partnering with faith communities in stopping the spread of this virus. And so tonight, with those themes in mind, and I'm sure our conversation will roll and go into other directions. We're blessed to have with us a panel of very able and committed leaders who are going to help us to explore these issues. And so allow me for a moment to introduce them. First, we have Bishop Thomas Brown, presiding bishop of the 6th Episcopal District, which is Georgia, of the Christian Methodist Episcopal Church. He also serves on the Interfaith Alliance to fight COVID. He also happens to be a graduate of Phillips School of Theology at the Interdenominational Theological Center. Welcome, Bishop Brown.
Thank you.
We also have Dr. Jeffrey Hines, Medical Director of Diversity, Equity, and Inclusion in the Center for Health Equity for Wellstar Health System in Marietta, Georgia. He's also the Chief of the Division of Gynecologic Oncology for Wellstar Medical Group. And he's a proven leader with expertise that he will bring to the table tonight in this field of diversity, equity, and inclusion. Welcome, Dr. Hines.
Good evening, everyone.
Good evening. We also want to welcome Reverend Dr. Curtis West Jr., who pastors Holsey Chapel, CME Church in Columbus, Georgia, and in his role as presiding elder in the West Georgia region of the CME Church, oversees 21 churches in the state of Georgia. Welcome, Dr. West. Then we have Dr. John Blevins, who is a professor at the Rollins School of Public Health at Emory University, where he directs the Interfaith Health Program, known as the IHP. And the IHP has worked in partnership with religious leaders and faith communities to address issues around disparities and to improve health outcomes in various communities in Atlanta and across the state of Georgia. He also happens to be a licensed minister in the American Baptist Churches, USA. You've heard from Dr. Akintobi, who is the principal investigator of the Georgia CEAL initiative, and we'll also hear a little later from Brittany Taylor, the project director of Georgia CEAL at the Morehouse School of Medicine. So to all of you, we want to say welcome. We also want to say a big word of welcome to those of you who have joined us in this virtual town hall. We want to make sure that you understand that this is not just a talking head moment, that we want to hear from you, right? And so we want you to type your questions in the chat. We want to hear from you, and we want you to know that this is a space where we want to hear your questions and your thoughts and your beliefs on this important topic, so we can be in conversation together, even in this virtual space. So as we set up this conversation, it's important that we set up this conversation with facts. Facts matter. and now facts probably matter more than ever. And so let's set the context with facts, and then talk about the relevance of faith community to those facts. So facts, as of January 29th, less than a week ago, more than 129,000 people have been hospitalized for COVID-19 in the US, which is up from more than 43,000 at the end of November. In that short period of time, the level of hospitalizations that we're seeing now, we haven't seen that level since January 2021, since that winter surge that took place at that time. From this short period, from late November to late January, the 7-day moving average of cases increased from 90,000 to 497,000 cases. And just in the last week, it jumped up to 723,000 cases. Also on January 29th, in late January, there were almost 17,000 new hospitalizations from COVID-19. Now, if we were to zoom out from the national scope and to zoom in to Georgia, the Omicron variant, which is 105% more contagious than the Delta variant, represented over 70% of cases in Georgia, whereas the Delta variant represented about 28.5% of those cases. And what that says is that in the state of Georgia, we've got some specific issues with regard to vaccination and unvaccination that we want to unpack, right? And so an unvaccinated individual's risk of death from Omicron is 10 times higher than the risk of death for vaccinated people. And the ratio for unvaccinated individuals who are hospitalized for COVID versus vaccinated individuals is approximately 25-1, right? So that suggests something about the impact of vaccines. And so in the state of Georgia, among vaccinated individuals, which is over 5.6 million people in this state, breakthrough cases are only 0.06% of the population. Hospitalizations, 2.2%. And only 0.5% of those who have been fully vaccinated have seen death as a result. And so in a real sense, what we're seeing is that these vaccines have worked to help to prevent not only the spread, but also the severe impact of COVID-19 on our communities. Facts matter, especially in this moment, right? And so what we want to explore tonight is, what does this have to do with faith communities, especially as we consider the disproportionate death that Black and Brown communities have suffered due to this virus. And I want to suggest that faith communities and faith leaders are underappreciated frontline workers in the fight against COVID-19. Amid the rampant misinformation that has generated and deepened mistrust, confusion among the population, communities of faith have served as trusted sources for reliable information, trusted sites for testing, for vaccination and education. But not only that, and we heard Dr. Akintobi refer to this, communities of faith bear witness to the human cost of the disproportionate death that our people have experienced. Faith communities and faith leaders are the places and the people that we go to share our grief, to lament our loss, to recover our hope, to pray for healing, and of course, to lay our loved ones to rest. And so in light of the facts of the pandemic and in light of the role that faith communities have played, we want to engage in a meaningful conversation tonight about where we go from here. And so in light of that, I want to first invite you, Bishop Brown, to talk a little bit about your involvement. You're a member of the Interfaith Alliance to fight COVID. And I want to ask you, what compelled you to get into the fight? And tell us a little bit about what you're doing in the community in Georgia and beyond to address COVID-19 in our communities.
Thank you, President Williams, my president, and certainly to my fellow panelists. Good evening. I was more than excited about the privilege that Georgia CEAL and Morehouse School of Medicine did in inviting me and other faith leaders to be a part of this enterprise. One is, as you just mentioned, that facts matter, but also faith matters. And as I saw the predicament we in our community was facing, it was just no other choice but to say, yes, I'll be a partner in this effort. And so for a year or two now, we have been working in this regard as a partnership. I have the privilege of serving, sometimes the burden of serving 285 churches across Georgia, many of which are rural churches. I saw this as a partnership that would allow me to be involved with both the institution that has the facts and the research that can help us with the vaccine understanding and to deal with not only hesitancy of people, but also to bring the faith to bear upon people's hesitance towards this. Forgive me, my tired tongue this evening. But I saw it as an opportunity for us indeed to bridge that gap. And throughout Georgia, I travel a lot, just got off the road why I'm a little late because my interfacing is with pastors and local congregations. And in that process, I've discovered that it's important to help people talk about their faith in relationship to the facts of this virus. And I've seen that to be a tremendous plus in this process. And so that's my major reason for getting involved with this. And we have been involving congregations across the state, from rural Georgia, South Georgia, all the way to Atlanta and Rome, Georgia, in this process, and have seen some results. Still, there are many areas that we got to cover, but and make some progress in, but I'm excited about the journey.
Thank you, Bishop Brown. And I also want to bring into this conversation Dr. West, who also serves in the Christian Methodist Episcopal Church in the state of Georgia as a presiding bishop, over 20 congregations and pastors in your care. What are you seeing and what are you doing in the state to address these issues around prevention practices, vaccinations, and the like?
Well, thank you so much, Dr. Williams, and good evening to each of you. First of all, when this epidemic transitioned into the pandemic, NBC, our local NBC station, invited me to come and to share some hope and some compassion to our community. And one of the things that we immediately saw were people dying. And I mean, in tremendous numbers, people were dying. So this virus was real. It was not anything that people were just talking about. We were seeing this in the church. And so one of the things that we immediately did was we transitioned from church attendance to virtual church. We shut down everything on our campus, and we had people attending virtually, but we also increased class leader systems and things of that nature. We encouraged people to wear their face masks. That was one of the first things that happened. Social distance, sanitizing, and we did our best to keep people informed. So everything that came down from the CDC, from the medical community, we promoted it. We even transitioned even our Bible studies into mental health conversations because we had to meet people where they were. And there was a lot of grief, of course, and no one knew what was really going on. So there were no real explanations. Then there was bad theology going on. Well, God is putting a curse on us and those types of things. And so one of the things that we did, we engaged people in conversation. And one of the last points I wanted to bring out is that we had lots of forums. And one of the things that happened in forums were people who resisted the vaccine were actually at least given a stage to say why they resisted, but we were also given a stage to confront their resistance. I don't believe you can transform a people without hearing people. And so we were not afraid to engage people. And we actually got a chance to see people change their minds about taking the vaccine. So those were some of the things, and so many other things happened along the way as well. But we definitely believed in confronting and comforting the people where they were hurting.
Thank you, Dr. West. And for those of us who are listening in, again, this is not a one-way. This is a two-way conversation. So we want to invite you to type into the chat your questions or observations. But as folks are kind of getting their questions and ideas in hand, I want to double back to you, Dr. West and Bishop Brown. You both raised some very important points around interventions in communities. And I picked up on what you said, Dr. West, around confronting and comforting. And so I want to ask you both to dig in a little further on the promising practices that you've seen in faith, and that you've also implemented in the face of this pandemic, early on and on through, to address issues of mental health, to address issues of hesitancy. You just named a couple of them, Dr. West. I want to ask us to go a little deeper and just kind of make visible some of those promising practices that you've implemented or that you've seen.
Well, if I may, as a bishop of 200 some churches, my first approach was to request pastors in particular to get the vaccine, but discovered there was great resistance to that among some people. And given my role and my authority, I thought perhaps if I said to people, if you don't get the vaccine, then this is going to happen or that's going to happen. I learned quickly that doesn't work. And so, as Dr. West indicated, hearing people out, even though I didn't understand or agree with what their perspectives were, but I always saw a relationship between their faith and the issues around the vaccine. It wasn't just the facts that people were the lack of facts. It was the fact that people's faith, as Dr. West indicated, people had to struggle with what they understood their faith response ought to be towards the vaccine, towards the virus. And in many of our communities, there is the idea that somehow if I've got faith, I can get rid of this. I can overcome this. And so faith was being misapplied or misused to address a pandemic and a virus that doesn't respond to faith. And so we had to help people bridge the gap between their belief system and what the realities were. And that sometimes is a major jump. I've had persons to use scripture. For instance, someone gave me Psalm 98 and said, "This is my vaccine. I just read Psalm 98 and it'll take care of me." You try to resist that kind of thought, but the fact is that's how a lot of folk operate. And so you have to give people time to get around that. But I also learned that the intersection between faith and the facts around this vaccine is layered with deeper issues. And so you have to help people deal with the emotional as well as the faith, religious matters, but also the peer pressure is another dynamic that people would ask, well, Reverend so-and-so is not taking this. Or I've had situations where a pastor's wife would say, I don't want my husband taking this. So I had to deal with that with several couples where the wife or the spouse was saying no. And when you ask them why, they weren't able, in many instances, to say exactly why. They just felt uncomfortable with it. And so you have to wait on people to talk to them through that. But I think one of the things we've done effectively is most of our pastors have at least attended workshops and training that has helped them understand the facts and begin to relate their faith to the facts of the virus and the vaccine. And of course, with the pandemic, most of our churches not meeting in person, that has been a challenge, helping people to bridge the gap between communicating via text, emails, and being in person with persons. That is definitely hampered us somewhat in that regard.
Thank you, Dr. Brown. That's very helpful.
To add, I was going to say, to add to Bishop Brown's statement, one of the things that I've tried to communicate to parishioners and to the public is that this is a communal matter more than it is just individual. And so we have to see it from a much broader perspective. We're all in this together. And I can't remember who said this, but I used this quote in defense, that spirituality is unseen science, and science is seen spirituality. And so when people try to misuse, misapply faith to this matter, many times we have to have something to say to them in response. But at the end of the day, I think if you engage people in conversation, if you're bold enough to confront the issues, I believe God will help us to get to where we need to be.
Thank you, Dr. West. That is a quotable. I'm sure someone wrote that down. Thank you for it. So we've got a question from one of our participants that we want to lift up. And although Dr. West and Bishop Brown have been our conversation partners thus far, we want to invite anyone on the panel to chime in. And this comes from JF Guider, I hope I'm saying his name right. He says there's a disconnect with millennials. So he's bringing in a generational issue. Perhaps, and we know this to be true according to some of the data, many millennials are not attending church at the same rates as their elder counterparts. Yet they hold a belief that the vaccine is, quote, the mark of the beast. So this goes to some of those issues that you just raised, Bishop Brown. How do public health officials, and so this sounds like this is a conversation for the whole panel, approach such declarations? How do you deal with that from a public health perspective? Not attending church, but applying religious imagery, symbolism, language to discount the science.
Dr. Williams, I can speak to some of the research we're conducting through the Emory program of Georgia's CEAL, where we're talking with religious leaders around the best ways to reach communities, particularly Black and Brown Latinx communities around Georgia, through faith communities and through religious leaders, and to multiply religious perspectives and messages. The first thing I would say in response to this question, it's a great question, is that I'm not sure that public health officials are actually the best equipped to approach these kinds of declarations. We can only do that in any way that is effective if we're doing it in collaboration and partnership with religious actors, clergy and laity, who are present in local communities and who have been present in local communities for a long time. Mm-hmm. We've been conducting key informant interviews with religious leaders around Georgia on the best ways to build those kinds of collaborations and partnerships and the kinds of messages we need. And their input to us has been exactly what was reflected in this question, that it's this generation, the younger generation, young adults, late adolescents, young adults, and adults into their early 30s, who are the hardest to reach. One of our key informant interviews, who's a religious leader, a well-respected and established pastor who's been in leadership both in academia and with concerned Black clergy in Metro Atlanta, had 3 suggestions for reaching young people. One is to challenge misinformation. So to challenge claims in which a message that the vaccines contain a microchip, for example, mm-hmm. and then to overlay that kind of message with the vaccines are the mark of the beast with religious imagery and language, to challenge that in direct ways. And he mentioned 2 ways to do that. One is to encourage responsibility across generations, that there's a connection between elders, between those in midlife and the younger generation, and everybody has a responsibility for one another. And so taking this virus seriously and figuring out our responsibility to be part of a solution to it is all of our responsibility. And then he suggested that we have to multiply messages and multiply instances where there's communication, that religious leaders are stepping up to the plate to get vaccinated, to vaccinate themselves, but also to amplify those messages and those images with others outside of religious communities or religious leadership positions also stepping up to the plate in regard to prevention and vaccination efforts. He actually mentioned his efforts in talking with young people that, yes, he's gotten the vaccine and he's talked with them about that, but then he's also talked with them that Jay-Z has gotten the vaccine, and that that amplifies a message of his own kind of social position in a community with someone else who's well-regarded and established and is looked up to. And he thinks those kinds of multiplications and connections are really essential.
We actually have good data that's out there that helps us establish who might be the best influencer for a particular audience. And there is some data out there that talks about, in addition to what John was saying about how you can pair people together. Can you pair a public health person with someone in the faith community, and perhaps someone in the faith community that's a little closer to the age of the people where some hesitancy exists, because the influencer needs to have that lived experience that the person who is hesitant has. And so there is some best practices out there that help us find who is the best influencer or the best messenger to carry the message which is going to have the best outcome for the lived experience that people have.
Thank you, Dr. Blevins, and thank you, Dr. Hines. Anybody want to add to that?
Yeah, one of the things that we've done is in our denomination is to pair young adults with religious leaders such as a bishop to talk about getting the vaccine done. We've found that to be fairly effective among young adults, because persons my age trying to talk to a young adult about getting vaccinated may not be the best approach. But when they hear other young adults who are their peers, age-wise, professionally, what have you, they're more inclined to at least listen to that person speak about their experience with taking the vaccine and their perspective on that. And so I would think that that is another approach. That clearly, if you're going to reach millenniums, you've got to have millenniums taking leadership in this, and not just those of us who are seniors.
The other thing that's helped us as well, too, if you go back to that lived experience, is to find that person who previously was hesitant, just like the millennials are, who eventually had the courage to get the vaccine, or who were afflicted by COVID and now can help other people understand better the importance of getting the vaccine. And those are the people that, for instance, we are focusing on mostly these days, because who's left out there that's hesitant they're a tough nut to crack. And some of the best influencers, again, I'm a big data person, what the science tells us are those people who previously were hesitant, who had that same lived experience that they have right now, who can come before them to provide information about hopefully giving them the courage to get vaccinated.
Thank you. That's excellent. So we've skimmed some the surface of a theme that seems to cut through this conversation about hesitancy, and that's the conversation around trust or mistrust of medical systems and information, and I would say that some of that trust has been eroded over the last couple of years through misinformation that was spread by one in one direction or another. But when we're talking about the Black and Brown communities, and more specifically African American communities, we know that much of that mistrust owes back to memories and even some misinformation about probably the largest one that looms in our mind is we call it the Tuskegee study, right? But it's actually the United States Public Health Service study of untreated syphilis in the Negro male. That's the proper name of it. And so there's a lot of misinformation about that, but I want to invite us to do some myth busting and ask you to talk about what some of those myths are. We've named a couple of them, but what some of those myths are that are contributing to vaccine hesitancy and to disbelief, and how we might cut through those with facts and with other kinds of interventions.
Dr. Williams, I think one of the issues, I kind of want to go back just a little bit to the disconnect with the millennials. But one of the things that has happened with millennials is that they've grown up, of course, a different time than we did, of course. When I was growing up, I was not given certain options. And so I was told what to do, what to take, things of that nature. It was not a bargaining issue. Even when it came to theology, we were told what to believe about God, about church, about Jesus, and so on and so forth. But this generation is totally different.
Mhm.
And so this generation requires listening, not giving answers, processing, not forcing. And so it requires us to rethink our approaches. And I think if we go back and revisit some of that, which is hard to do because we are caught we're caught between a rock and a hard place because of how we were reared. But this generation is going to require a lot of listening, not forcing anything. And I believe in time, people stumble upon the answers. And when the facts are there, eventually people will get it.
Thank you, Dr. West.
The other issue that we're dealing with is we are in an age, how to put this, where gambling has become a mainstream part of people's lives. And I've heard people say, in terms of dealing with their chances, they would rather gamble against the virus than to take the vaccine. So I think part of what we're dealing with is it's a whole cultural shift that's taking place, not just among millennials, but some of the older persons as well, is that somehow I can beat the odds. Even when we see funerals being held and we know people who are dying of the virus, I've noticed among some persons, there's a sense that somehow I can beat the odds. And that's another issue that I think, to talk about with Dr. West and my age particularly, people didn't take the kind of gambles that I see people doing now. There was more community enforcement and village life that kept reinforced that. Now people take those chances, and there is a sense that death won't catch me. I can outsmart it. So that compounds the issue for some persons.
Thank you.
I think what also compounds the issue, unfortunately, and the elephant in the room, is the tribalism in politics that exists these days.
Yes.
And so many decisions that should be medical decisions or public health decisions have an overlay of the tribalism and the politicization that exists in our country. And I don't think, I've been practicing medicine for, almost 40 years, and I have not seen this divisiveness that we're seeing right now that is overlay with tribalism and politics. Let me give you an example. I'm an oncologist. I give people chemotherapy every day, and the chemotherapy is significantly more harmful to people than the coronavirus vaccine. And even some of my patients, when I bluntly pose that to them, they take issue with it, and the issue that they bring up is more of a political issue. How you fight that, though, is I agree, through listening, but facts. And part of what we have to overcome is this device as well too, and that's been the game changer. Certainly, because if you look through history, there have been problems with the rollout of other vaccines. And, Dr. Akintobi can probably attest to this, when measles was rolled out, when the HPV vaccine was rolled out, there was, a concerted group of people that would voice their concerns, but it is amplified by this device. And, there are medical schools now that are teaching courses on how physicians and other public health officials need to be able to figure out how to fight against social media.
Thank you. Any other thoughts on these kinds of approaches that break through the veil of misinformation and mistrust?
Well, I think the other.
Let me also.
Go ahead.
No, Bishop, I'll yield to you.
Well, from my perspective, in terms of Black people, or Black and brown people, in terms of medical people, going to doctors, for instance, is still a challenge for many of our people, especially men. And so that's another underlying issue here of not wanting to to know information unless I have to in some instances. So I think you've got that strand in this whole element of people not trusting doctors or not wanting to go to doctors for fear of what they may find out.
And I've had parishioners who received the first vaccine and they became ill. Mm-hmm. And their voice was actually louder than some of the people who promoted the vaccine. It promoted fear. And, mm-hmm. Those are some of the things that we have to wrestle with as well.
Absolutely. I think one of the things that all of you are beginning to underscore is that what we're seeing in terms of the disproportionate impact of COVID-19 was already sitting on a situation of health inequity.
Yes.
Right? That health disparities was a pre-existing condition of the United States, right? It was a pre-existing condition of our community. And so now here comes COVID-19, and the disproportionate impact just swells and yawns in the face of that. And so there's a broader kind of relationship, right, to medical care, quality of care, access to care that sits underneath that. So I want to ask Dr. Blevins and Dr. Hines, how are you thinking about being in conversation with communities and overcoming those kinds of barriers, even from a broader perspective, to help folks begin to gain access to quality care and to address those broader issues around disparities?
Yeah, I'll start. I think that is actually the core of a lot of the issues that we were talking about just a moment ago in regard to misinformation and disinformation. Mm-hmm. I don't think in public health we've done a very good job historically of creating partnerships that are based on relationship. I think we tend to go in and think strategically about partnerships in local communities to get the things done we want to get done, and not always listening to communities about the partnerships that also address and respect the priorities of those local communities and the people in those local communities. And so a lot of what we are learning the hard way in response to this pandemic is in relation to working on the ground in local communities. We don't have the infrastructure built that represents holistic, sustained, mutual partnerships that where people come to the table in equal measure and as equal partners. Instead, we've got this history in public health of coming to different sectors, and we periodically come to the faith sector to conduct our community outreach or our community-based participatory research.
Right.
And communities get tired of that. They get tired of being treated as subjects for research. They get tired of public health officials showing up around a topic that they're funded to work on, but not necessarily addressing some of the broader kind of structural, endemic, sustained structures in American society that create health disparities in the first place and that contribute to inequities across the social sphere, including within health. And so what we are having to learn, and we're learning it the hard way in regard to COVID, and I hope we are learning it, I'm still not sure we are, is that we've got to be much more holistic and comprehensive in thinking about what partnerships look like. And we've got to be much more egalitarian at coming to the table, not as experts to tell communities what it is they need to do to implement the things we've studied, but to recognize that the knowledge and wisdom of communities is the essential starting block and starting point for all kinds of issues, COVID and other issues as well. And in time, that can build trust, but it won't be built immediately. And we've got to start demonstrating those kinds of qualities and characteristics and commitments in order to begin that process of building.
I'll second that and take it a little further. You're absolutely right, John. Part of the issue is that disparities have been muted and ignored for decades. the disparity between people of color, or even if you look at rural and urban, and many of us, have churches that we shepherd that are in rural areas. If you look at the disparity in health outcomes in rural versus urban communities, Black and brown communities, those disparities have existed for decades. And so much of it is based on, and what John was alluding to, and I'll call it out, and many of us have heard now, what are called the social determinants of health.
Yes.
And those are those aspects of how we live, how we work, how we pray, how we die, how, everything that we do. And it's all resourced, and it's all based on disproportionate resources. And so if you don't have good access to healthcare, you're going to have a poor health outcome. If you don't have good access to education, employment, you're going to have a poor outcome. And so we need to bring infrastructure. And that's one of the things I'm glad to hear that John is doing at Emory, that we're doing at Wellstar, is to really think more holistically. That ecosystem needs to include the neighborhood. It needs to include education. It needs to include employment. It needs to include transportation. It needs to include food. All of those are meaningful drivers of health. And that's why these disparities have existed for so long. We don't need another commission to look at why these disparities exist. We need to have meaningful conversations and convene and collaborate the right partners to the table to move things forward.
Thank you so much, Dr. Hines. Dr. Akintobi, do you want to come into this conversation?
Well, I wanted our panelists to take center stage, and they've only called me back because what they're saying is resonating so well with the intent of Georgia's CEAL. Dr. Hines, you really hit it, as well as you, Dr. Blevins, and all of you, and that is that community co-creation of the solution is essential.
Yes.
We must have equal footing in determining not just the color of the furniture in terms of the response, but what is at the root of the issue. And Dr. Hines talked about the social determinants, and he alluded earlier to the political determinants of health. We're also clear, based on the data, that there is almost a direct overlay of the political color of a county or geography, the degree to which masking and other mitigation strategies are required, and COVID positivity and vaccination rates. There's something that we need to do about that. And it requires that not just researchers and clinicians are at the table, but local policy systems and faith influencers help us to not only understand, but to respond. So this is a really inspiring discussion, and I love the chat. So hopefully we can look at it and see some questions and comments that have come through.
Indeed. So
Certainly right across the street from my brothers and sisters at Morehouse is the Satcher Leadership Institute. And
right.
Daniel Dawes, who is the author of The Political Determinants of Health, makes this great argument about the importance of the three political determinants of health: government, voting, and policy.
That's it.
Is critically important. And just like Dr. Akintobi just mentioned, if you look at some of those surveys that have been published for the past 2 years about the percent of different communities that mask, that socially distance,
Right.
that get the vaccine, there is a blue-red, dynamic to that.
That's it.
So clearly, tribalism and politics plays a role in all of this.
Excellent. Thank you.
Yeah, and the other point that I think, from my perspective as a faith leader, is that this is perhaps the first time in our history that the church has been called on to take on such an advocacy role as regards to health. And so there is a learning curve taking place in terms of what ministry going forward must look like as well.
It's a very important point. So that suggests something to folks like me, Dr. Brown, Bishop Brown, who are in the business of preparing faith leaders.
Yes.
Right?
That's
to
right.
think about what's required in their formation to prepare them to be the kind of leaders that our communities need now. So I'm taking a lot from this conversation as well, and I appreciate it. So I want to lift up a question that came from our audience that goes back to something that you mentioned, Dr. Hines, about disparities in rural versus urban communities. But then when you dig a little deeper, there's a rural disproportionality with regard to white versus Black health outcomes in rural white and Black communities. The person asked, how do you explain this phenomenon?
You know, unfortunately, that phenomenon can be easily answered through, you know, our long history of racism in this country and how it has affected, for instance, the ability for people to get access to care. And those, you know, those problems have been existent in, you know, for years. I'll give you a couple of examples. If you look early on in the pandemic, early 2020, you know, one of the most significantly hit communities in the country was Albany, Georgia. And it, you know, was the Black part of Albany, Georgia that was significantly affected. And so much of it dates back to generational and historic disproportionality and generational and historic oppression that's happened. And that's been the difference. As a GYN oncologist, there was a paper that was just published last week that looked at rural Black and rural white women, and the incidence of cervical cancer was much higher in those rural Black women compared to rural white women. And again, it's all due to generational and historic oppression. So much of it is.
Yes, indeed. Dr. Akintobi, I want to ask you to dig a little further on this idea of community co-creation, right? And the implications of that, both for these disparities with regard to COVID, but also for the broader issue of health inequity.
So there's a script that we must flip, and you know, all of us who are on this panel are in a quest to get it, to maintain trustworthiness. But even in the titles and the organizations that we represent, we still must strive to address and combat how the seats that we fill represent a difference and a distinction or a schism between communities and neighborhoods who are disproportionately impacted and those of us that are trying to make a difference. And so the community co-creation requires humility, and I think Dr. Blevins said it well, a positioning of all of us to first understand, then to consider what community and neighborhood residents value, and take from them their best wisdom on how programs and interventions can be developed with them at the helm. And so stated differently, clinician and doctor do not know best. We may know the science, but in terms of how it will be received and who the messenger should be in the delivery of that intervention and how it can be sustained is not an answer that I have. And so through things like Georgia's CEAL, we have a community majority coalition board, and some of the folks that are part of this are reflected there, such that I at Morehouse School of Medicine and others who have academic seats like Dr. Blevins are in the minority, because even though we may look different, we still represent the academy. And so that flipping of the script means that they have the voting power. They are at the helm in terms of the decision making surrounding CEAL. And what we hope at the end of the day is that this model really prepares us for what will be next. COVID is just the public health issue of the day, but community leadership, not advice, is central to the path forward, and that's what co-creation with communities is about.
Thank you for that. And I want to just lift that up and reinforce that and put that in a megaphone and on billboards in a way that just needs to be amplified, because the flipping of the script the importance of the flipping of the script cannot be overstated. And so I want to refer back to something that Dr. Blevins mentioned about this issue of trust, and that so many of our well-intentioned interventions are impacting in ways that we didn't anticipate, but were really a matter of design, right? And that we thought we had answers for communities as opposed to developing answers with communities. And I'm reminded of our friends in the disability rights advocacy movement who say, nothing about us without us, right? That you don't design interventions or programs or policies without consulting the people who are most impacted by those issues. And so I want to say how much I appreciate the approach of Georgia CEAL in lifting up really an asset-based approach to addressing these issues. Thank you so much. So I want to now turn our attention to some resources. And first of all, there are resources sitting here on the screen. And I want to just lift up an opportunity for each of you to talk about how those of us who are viewing and are participating in this conversation can interface with the initiatives and the programs, the congregations that you're a part of. What kind of opportunities are there for folks to access the work that you're doing?
I'll start with some resources that we have within the Interfaith Health Program at Emory. In relation to COVID, one of the things that we began to do immediately, and we work in Georgia, we also work in other domestic programs in the United States, but a lot of our work, and most of my work actually, is in global health. We work with our faith partners from different religious traditions in different parts of the world to begin to gather resources that were being developed for congregations, for Christian communities, for Muslim communities, Jewish communities, and to put those on our website for clergy and laity and lay leaders to access in regard to safe worship practices, resuming in-person worship and things such as that. They're still up, and we are always happy to add more to the resources that are there. We work to develop some resources with ecumenical partners around the world in regard to prevention messages, particularly developing guidelines and practices that were relevant for households where most of the people in the world outside of North America and Europe reside, that are multi-generational, 1 to 2 room households, where we talk about quarantining in place doesn't make any sense. It's just impractical and unfeasible and irrelevant. And so developing some alternative kind of programs in regard to that. Those kinds of materials are there. We would love to hear from others who have developed materials and to spread that. And if there are gaps in what's there, please let us know. We also have materials on that website of theological reflections from various religious leaders in response to the epidemic, and would be happy to include more of those, either that you've published or that we could work together to publish from various religious traditions. And then we've got a series of interviews up that actually address some of what we were talking about before, about what COVID reveals around structural inequities, historical disparities, structural and systemic racism in the United States, and public health, community leaders and religious leaders being interviewed around those kinds of intersections and what COVID revealed to that. So those are resources on our website. We'd love to add to that as well. We're continuing to talk to religious leaders, both lay and clergy, to get your insights as to what Georgia CEAL needs to do now and in the future, as we look and hope for future kinds of ways to build collaboration that ties to what we were just talking about. What does it look like to build these partnerships in a way that when we get down to, hopefully we'll get here, COVID cases being very low on a daily count basis, that we don't pack up our tents and go back to our academic settings, but that the relationships and networks that have been built through Georgia CEAL then are pivoted to address other kinds of health needs and health challenges in local communities in a truly community collaborative way. We're seeking input from you around what that should look like. So if you'd be willing to be part of a focus group on your insights and input on that, we'd love to gather that from you and to have you be part of that and to help us amplify your voices and your wisdom in regard to that. We're holding a town hall on the 26th of February, a Faith Leaders Forum. We'll advertise that in a moment. But we also invite you back to that as well, where we begin to talk about, under the theme of love, mercy, and do justice, referencing Micah 6, what does it mean to build true partnerships in local faith communities, between public health and faith communities, to address health disparities beyond COVID? And so those are the kinds of things we're doing, and want to invite you to the table around that. We need your voices and your wisdom.
I'll follow.
Thank you, Dr. Blevins. It appears that we may be having a few
I'll follow up.
Thank you, Dr. Blevins.
Some of our resources are still kind of the boots on the ground work, and we are still in a regular cadence of vaccinating people. We have a very well-developed and robust congregational health network where we actually send mobile units out to partner churches where we vaccinate people. We try to reach those faith communities a few days in advance to do education and outreach with appropriate influencers. And as much as possible, we try to do our vaccines on day that these churches, for instance, are addressing food insecurity, because food insecurity is still a huge problem in our communities. So that's kind of the boots on the ground work that we're doing. I'm also excited we're about to launch a program again through our congregational health network, and we're looking for other partners in conjunction with the Atlanta Regional Commission, something called Soul Support, where we actually are going to partner with faith-based organizations and offer a mental health first aid course, offer something called QPR, Question, Persuade, Refer, and to give some tools to help caregivers. So we're proud to partner with ARC. We're excited to put this on the Georgia CEAL or the NCRN network to talk about some of the work that we're doing both on the ground to get people vaccinated, because that's still critically important, but also some work addressing some of those issues that we talked about at the very beginning, in particularly mental and behavioral health.
Well, this sounds exciting to me as a faith leader. I sure would hope that we would not limit our partnerships to just a crisis. It's imperative that we be more proactive going forward.
Thank you, Bishop Brown. So important.
I just wanted to respond to a question in the chat from Silas Buchanan, I hope I got the name right. Where and how are we training health ministers to lead in our communities? One of the things that we hope we will be able to implement in Georgia CEAL with some funding that we have applied for is to amplify the work of health ministers and health ministry programs in local congregations around Atlanta, not only in relation to COVID, but actually in relation to some of the other kinds of health priorities in local communities, and to bring health ministers and local congregations to the table for some of those efforts. So that's actually something that's in a development phase that we're talking about within Georgia CEAL. And Silas, we'd love to have you be part of that kind of effort as well. So please reach out and be in touch in regard to any work and any relationships you have with health ministers and health ministry programs around the region.
So I'd love to, while Reverend Dr. Williams gets back with us, to ask Brittany Taylor to talk a little bit about the event that Dr. Blevins alluded to. This is an open invitation, so Brittany, if you would.
Good evening, everyone. Excuse me. Thank you all for joining us this evening. Yes, so we will be having, sorry, my computer. We will be hosting a faith influencer convening on Saturday, February 26th from 10 a.m. to 1 p.m., where we will be bringing together various faith leaders and influencers from all different levels to share on what is best and how to approach COVID-19, as well as other topics and issues in these communities, and to bridge the gap and also create a path forward respectively. So we will be sharing that information a little bit more. There we go. Thank you, Ornike. In just a second. All right, so I am going to share with you all some Georgia CEAL community resources that you all can use in the communities where you live, lead, and learn as well. So here at Georgia CEAL, we are focused on increasing communication around COVID-19, best practices, prevention and protection, boosting COVID-19 confidence and trust, and of course, increasing vaccine uptake, and all the while making sure we're encouraging everyone to continue getting tested so we can ensure we are protecting ourselves and loved ones. So here are a little bit of resources that we share and that are available for communities. We send these out. We post these on our social media platforms and pass these out at events that we're attending in order to educate and empower residents and citizens in Georgia and beyond. And so here are some examples of what our partners in the faith community have done as a part of Georgia CEAL and on their own. Dr. Blevins referenced the economical tools that they have been creating. And here's just an example of that, available in both English and Spanish. We have our partners also, Georgia Arrhythmia Consultants, that have been conducting workshops. As we know, not all of the churches have reopened, and so they're still conducting workshops on reopening and resuming services in person when they would like and are ready to do that. And so Georgia CEAL is part of the NIH CEAL network, and they provide information and resources in the form of fact sheets, toolkits, videos, and websites. So here is just a quick view of what that website looks like. It's available in English and Spanish. You can just click on the website and explore these various topics. We also have the We Can Do This educational public health campaign. And when you log on to that website, there is a great search bar where you can just type in what you're looking for, and it brings up a lot of different audiences and topics you can speak to. So you just click what you would like. And as you can see here, they have specific information geared just for the faith community and beyond. Greater Than COVID is also another great resource and campaign. They've called together a very diverse group of public health, medical leaders, researchers to empower everyone to come together in unity and beat COVID-19. Beat the Virus is a really quick website you can go to just get a great synopsis of vaccinations and cases across the US. They keep a scrolling bar down at the bottom of their website. So if you just want to go there really quickly, you can do that without having to dig through all the CDC data. Made to Save. They're saving everybody and focusing on the COVID-19 vaccines and teaching everyone how to do so through different resources, social media trainings. So that's a great way to reach the youth community as well, as we were speaking of earlier, those millennials. And last but not least, there are the Faiths for Vaccines multi-faith movement. And you can get to that website through Faiths for Vaccines. And they are specifically focusing on bringing everyone together for equitable vaccination distribution. So what have we done as Georgia CEAL? We have collectively distributed and administered over 65,000 vaccinations among community residents and healthcare professionals, paired with the Mexican Consulate of Atlanta. We've paired with our local health departments. We have Dr. Hines and Wellstar also conducting pop-up mobile vaccine clinics. And we at Morehouse School of Medicine have also conducted mobile pop-up clinics and drive-up clinics, along with the Cobb County Board of Health conducting vaccine rallies where they distribute $100 gift certificates to those who come and get a vaccine dose. Georgia CEAL has also done a media advertisement campaign empowering everyone to hopefully go and get their COVID-19 vaccination by sharing what is our why and why did we go get vaccinated. And here are a couple other resources that we provide as Georgia CEAL. So fact sheets on the vaccines, flyers. There is a COVID-19 health equity dashboard that you can access and find up-to-date information in Georgia communities as well as nationally. And then we also provide Georgia CEAL resource kits. And in these kits, you have protective equipment such as masks, gloves, hand sanitizer. You also have a pen to write down important facts and information that you need to receive. And so we pass those out at community events. We have partnered with Combat COVID to host a COVID-19 Navigator training session, empowering people who work in the community settings to learn about COVID-19 and also train others on COVID-19 so they can address clinical trial hesitancy and recommend COVID-19 treatment options. And here is a flyer for the event Dr. Blevins and Dr. Akintobi mentioned, where we are calling all faith influencers to do justice, love, and love mercy. So we'll be coming together and articulating the mission and vision of the group we're convening, and then encouraging networking across all of the communities and programs that will be joining, and then a big emphasis on building capacity to ensure that everyone is able to take this information and these resources that we are looking to help you build back to your communities and empower public health prevention measures and practices for you all to use in the communities where you live and lead. And last but not least, here is our contact information. So you can send us an email or you can give us a call, and we would be more than happy to help you, partner with you on any of your needs, and also send you resources. So that is just a little bit about Georgia CEAL, and I am going to turn it right back over.
Thank you, and I'm back from a technical difficulty, and glad to be back in the conversation. But thank you for filling us in on those resources and ways that folks can plug in to take their next steps. I want to address one question that came up in the chat about where ministers who address issues of public health and healing are being trained. And I'm happy to say that ITC, the Interdenominational Theological Center, is one of those places where, like our beloved Bishop Thomas Brown, students are coming to understand what it means to be prophetic problem solvers, to address these social and political determinants of health and healing from a faith-rooted perspective. So there's been a long-standing and continuing legacy of ministers, pastors, and faith leaders in other vocational paths who are learning the work of pastoral care, chaplaincy, and also work in health-related fields. And so look us up. We're one of those places, as well as Rollins School of Public Health and Candler School of Theology, where they have a joint degree there. There are multiple places.
So hopefully Reverend Dr. Williams can rejoin us, but I'm going to put information in our chat, which hopefully our Ms. Oronike can put into the live chat about the ingredients in the COVID-19 vaccines. There was an important question surrounding whether the remnants of human fetuses are included, and the answer to that is absolutely no. And so there are facts and myths that we want to certainly be sure to dispel, and the information I'm putting in the chat gives you all of the information surrounding the ingredients in the authorized COVID-19 vaccines, and they have all been emergency use authorized so that they are safe and certainly do not include ingredients as were described in the comments. So we're here to share the facts and to answer and create a safe space for every question and comment, and we hope that this one will do that. So we hope.
I just want to lift up one last thing. You know, there's a rich, robust history of the faith-based community being involved in health advocacy. And I'll read this quote, and everyone knows it, by Martin Luther King Jr. Of all the forms of inequality, injustice in health is the most shocking and inhumane. So there is that strong legacy of advocacy of faith leaders around health issues.
Thank you so much, Dr. Hines. I want to thank all of these partners in good, Dr. Blevins, Bishop Brown, Dr. Reverend West, Dr. Hines, and our moderator, Dr. Reverend Williams, for taking the time to share from your experience and from your purpose and passion, and all of you that joined us this evening. This is not just a dialogue for your thought and understanding, but hopefully to motivate you to action. So we have all of your information, and certainly we'll share the details related to the February 26th event and all things Georgia CEAL, so you can be armed with information and resources to understand, to act, and to recover from the pandemic. Thanks, everyone. Stay safe and stay well.
Thank you.
Good night.
Thank you.
Good night.
Thank you.